Welcome to the last and hopefully final portion of Module 8. And we're going to be talking right now about essential, as in primary, and secondary hypertension. Okay, again, we're still on hypertension. The essential hypertension is, well, you don't really know why. Okay, so it cannot be defined, the exact cause of why you're getting this. Alrighty, so it is hypertension. They call it essential hypertension because they really don't know for sure. Okay, there's at-risk factors like a family history, or age, or obesity, sedentary lifestyle, of course, and these are all typically risk factors for any hypertension. But in this case of essential hypertension, it's kind of a separate little category where you can't say any particular patient has enough of any of these at-risk population factors that can say for sure that's why they have it. This is a person where you're like, I just have high blood pressure. I, may or may not have some of these, factors involved in it, but but it doesn't really explain it. Okay. Secondary hypertension is what we're typically used to, I think, where there's some kind of identifiable abnormality. Again, it's usually one of these things up here that are identified, but at least we know what it is, and that's where you see where you can actually do something about it. It's a little harder to fix the problem with essential hypertension, but you certainly can treat it with medication either way. Okay, metabolic syndrome. I don't really know for sure how old this syndrome is, because it reminds me kind of like chronic fatigue syndrome, where you have some of these things going on and you kind of throw it all together because you're not really sure exactly what's causing what. It's just an association. Okay, there's definitely a link or an association between some of these things that you can clearly see the link there, but you really don't know exactly how they're relating necessarily. All right, so insulin resistance. So you might have diabetes, but not necessarily. Insulin resistance. Hypertension, again, it could be essential hypertension, or it could be secondary hypertension. So I mean, you may or may not know the reason behind that. Cholesterol abnormalities. Okay, again, you kind of have the same thing going on with the essential hypertension, because there are certainly a lot of people that have very high cholesterol that it makes no sense why. Also, anyway, increased risk for clotting. Okay, this is the one that's a little bit unusual, so I'm going to kind of star that a bit. And then abdominal obesity, as in a fat tummy, right? So you think about this. You got insulin resistance, possible diabetes or pre-diabetic. You got high blood pressure. You got cholesterol problems. You got abdominal obesity. Okay, this is pretty typical, right? Down here it says 20 to 30% of the population in industrialized countries like the United States have this metabolic syndrome. Pretty typical, especially you see the 45-year-old male with sitting on the couch watching NFL football. This is pretty typical person that we're describing here, instead of calling your patient just a fat dude with a lot of risk factors for killing over. We call it metabolic syndrome. Okay, the only unusual one here out of that is increased risk for clotting. That's not necessarily related to what you typically see. Okay. Waist circumference. Alrighty. Well, we do have some parameters. Okay, so you're talking 40-inch waist in a man and 35-inch waist in a woman. Your triglyceride levels, 150 or higher. These are not the same as your cholesterol levels. They are triglyceride. They're a little different. Your high-density lipoprotein, or your HDL cholesterol, that's the good stuff. Okay, it's less than 40, and there's the definition there in men. and less than 50 in women because they don't have as much muscle mass, and actually the HDL, good cholesterol, is definitely related with the amount of muscle that you have. Blood pressure 130/85 or higher. Okay, so you're almost what you would call high blood pressure. You're definitely not normal blood pressure, you're somewhere in the middle. Fasting glucose of 110 or higher. Okay, this is fasting. Again, you're not till diabetes until you hit what, 125? So 110 is not quite diabetes. Blood pressure is not quite high. The cholesterol levels, as far as the muscle part of it goes, you're talking about the HDL here. The triglyceride levels. The waist is, a little bit big. So not necessarily, being wiped out by any one thing. It's just kind of a little bit of everything. All right. So, of course, people with this being fat disease, you, of course, have an increased risk of developing diabetes, having heart problems, increasing risk of dying from all causes, including heart problems, cardiovascular disease. And the reason there's limited information about the prevalence of the metabolic syndrome is because I think it's kind of, I don't know, kind of iffy. You don't see a whole lot of doctors necessarily diagnosing somebody with metabolic syndrome. They'll diagnose somebody with high blood pressure or fasting, or diabetes or something like that. Apparently, though, they have a lot. Okay, somebody's keeping track of that somewhere. Alrighty. Ooh, dizziness versus vertigo. Alright. Dizzy. If you are dizzy, we know what dizzy is, right? Dizzy is when you are disoriented. Well, okay. Disoriented in space, unsteady, lightheadedness, confused, weakness, or about to faint feeling. Everybody's been dizzy, right? Okay. That's what dizziness is. It's the whole unsteady, dizzy kind of thing. Now, if you look at vertigo, or let's actually mention these signs and symptoms: lightheadedness, disequilibrium, or about ready to fall over, being lightheaded. Vertigo is a sign and symptom of dizziness. Okay, what's vertigo? Well, vertigo is things are moving. All right, so either the patient or the environment. If you're spinning, that's subjective, as in you're the subject, and you spin around. If the room is spinning, that's objective vertigo, and that means other things are spinning around. Okay, so the vertigo part of it is the spinning part of it. The spinning part of it can be part of the being dizzy. So dizzy is like a overall kind of catch-all, and vertigo is the spinning part of it. And sometimes you get it from being really, really, really high up. Okay, same thing here. The vertigo, illusion of movement, either you or the surroundings. So the causes, most common, benign paroxysmal positional vertebrae. Okay, vertigo. Yeesh. Benign paroxysmal positional vertigo. Okay. That's, well, let's break it down, I guess. Benign, all right? It's not it's not necessarily going to kill you, okay? Paroxysmal, as in it's a paradox, okay? So it doesn't really make sense, okay? It shouldn't really happen, I guess, is when you're talking about anything that's a paroxysmal cause. It's a paradox. It really doesn't make sense. Okay, maybe that'll make sense here in a second. But and then positional, of course, depending on your position and vertigo. All right. So, for example, let's think about trying to think of any kind of specific example of this. Yeah, I may have to get back to that where I can think of a specific example, but maybe every time I turn on my right side, everything starts spinning around. Or Underdog had this. I don't know if any of you guys remember, probably not, the Underdog cartoons from way back long time ago, but it was a cartoon, not a movie, right? And Underdog, he used to say, "I feel fine when I lay down, but when I stand up, things spin around," right? And that was his thing. It was only one episode, but he was really sick, and he had like benign paroxysmal positional vertigo, and he couldn't fly, and he couldn't do his Underdog stuff and catch bad villains. Anyway, that's kind of what it is. It didn't necessarily make sense. You go in, you can look at the different things in the eyes and ears and all that sort of stuff, and you still never really figure out exactly why. Alrighty. The dehydration, hypotension. Okay, so if you're dehydrated, then it could definitely lead to vertigo, just as hypotension could. So what happens is these little guys down here, your inner ear ossicles, and this part about the vestibule is the area right in here, and then along with it, it has these semicircular canals. Well, these semicircular canals, there are 3 of them, and they go different ways, so it makes everything 3-dimensional. Okay, well, the whole deal with that is that's your balance. So no matter which way you're turning, which way you're positioned, one of these, or not one of them, all of them, they're filled with fluid, this endolymph, and that fluid moves around and it pushes on these little hair cells, basically, that knocks them over, and anyway, it sends a signal back to the brain that says, what position you're in at all times. Okay, so can you imagine if you are dehydrated, this fluid inside of these semicircular canals, as it's trying to move around as you change your position, maybe it's really thick because you're dehydrated and it really can't do the job, and therefore the signal throws off the less fluid in there throws off your balance, because the signal is not getting through, it's not pushing the right hair cells over, and it's just not responding like it should. Okay, same idea with hypotension. You don't have enough blood flow in here, then you don't have enough pressure in here, and it's going to, again, this isn't blood, but it's fluid in there, and it's regulated by blood pressure can increase or decrease this. So that's going to be one of the things that also is going to manifest as in dizziness. Okay, motion sickness. Okay, you get vertigo from being motion sick. Again, it has to do with the same kind of thing. It's just that some people will get motion sick even if they're feeling normal and they're not dehydrated or hypotensive or anything like that. Okay, of course, because this is all in the inner ear, then an ear infection would do that. And these labyrinths, they're called. I call them the semicircular canals, which technically, they are the semicircular canals, but they're also called the bony labyrinths, okay, because they're bones and it goes all these different ways and whatever. Okay, MS is multiple sclerosis. Okay, multiple sclerosis is a nerve problem, but that could also lead to vertigo, because your nerves, of course, innervate. They come down and they innervate, these inner ear, and say for example your cranial nerve 8. That's 8. I don't know why I put the C there. Cranial nerve 8 is your vestibulocochlear nerve, and the vestibule, this is the cochlea part right here, but the vestibule is that part of it, the body and the semicircular canals. But if that nerve is messed up from, say, example, any reason, and including multiple sclerosis, then of course you would have vertigo. Whack yourself in the head really bad, things spin around. Okay, bad enough migraine will give you vertigo, make you spinning, you or the room spinning. Okay. Wow, look at that. Signs and symptoms of vertigo are dizziness. Okay, so it kind of goes back and forth that way. We use them pretty much interchangeably, to be honest, which is why you kind of see that kind of thing. Unbalanced is probably more more, I don't know, I guess it's probably more dizzy than anything. Lightheaded again, dizzy. The spinning is definitely the vertigo, nausea and vomiting, you know, probably from the being dizzy. But either way, dizziness, vertigo, hard to distinguish between the two unless you just remember that vertigo is a spinning portion of all of the things. Okay, and then of course you have vertigo as in I have vertigo, or I'm experiencing vertigo because things are spinning around, or you have vertigo, the actual disease from maybe, you know, BPPV, you know, vertigo, as in it's an actual something. Okay. Well, what do you want to do? You want to test all this with a CT. Again, you might have some kind of tumor. It's not really listed here, but maybe you got a tumor pressing on something and throwing off your balance. Okay. EKG, maybe you're getting vertigo because you're simply having a heart attack and you're not getting enough oxygen to your brain or to your ears, inner ears. Maybe your glucose is too high. You could get too high of sugar, and that can start destroying nerves. Okay, so, and then there's particle repositioning that actually I have no idea what that is. Now that I think about it, I'll have to look that one up and get back to you, or your teacher will. Alrighty, this is your ear anatomy. Okay, so we were spending all the time around in here looking at that. This is the body of the vestibule. Okay, and you have a vestibular nerve that comes down there, and then you have the cochlea. This is the part where you hear from, the cochlea over here, and that cochlea has its cochlear nerve. Eventually they both meet up together somewhere in here and they make that cranial nerve 8, the vestibular cochlear nerve. But anyway, this is our little semicircular canals or bony labyrinths or whatever you want to call them. Again, there are 3 of them going 3-dimensionally so that that fluid can flow through the center of these things, and no matter which way you're going, it's picking it up. Okay? Other than that, I'm not really sure what to add to this. Okay, Menieres disease. Menieres disease is a inner ear, which is what we were talking about, that, you know, the vestibule and the cochlea. Okay, so the vertigo and hearing changes, it says, or you typically hear about hearing loss, but it could be just buzzing or something. But so vertigo would have more to do with that vestibule part of it, and the hearing problems would have more to do with the cochlea part, right? Well, in either case, Menieres, I like to think about it like men's ears disease. Okay, so men's ears disease, or Menieres disease, has to do with men. No, not necessarily men, but it has to do with ears, right? And you can have, you know, the hearing and the balance problems. Okay, now anytime you see a triad of something, that means that you have to have all 3 of them. You have to have vertigo, in this case tinnitus, and hearing loss to have it called Menieres disease. Okay, if you have vertigo, you just have vertigo. You're dizzy. If you have tinnitus, that's just ringing in the ears. Okay, if you have ringing in the ears, they call it tinnitus. If you have ringing in the ears along with a hearing loss and vertigo, then that's the triad that you need to say this person has Menieres disease. Most of the time, only one ear is affected. Okay, for whatever the reason. And Menieres disease is one of those things that kind of comes and goes. So between the attacks, you're going to get your hearing back. Okay, causes. Again, we're kind of talking about the fluid changes, right? The things caused by maybe dehydration or high blood pressure or something like that, because of those semicircular canals and that endolith flowing through them and trying to give us our little gyroscope with the fluid going all over the place. It does cause an imbalance if if the fluids are messed up from whatever reason. We already said trauma, infection, ear infection, allergies will cause a little bit of exudate or a little bit of fluid changes inside that inner ear. Anxiety, stress, again, probably, usually when you hear anxiety or stress, you automatically start thinking of cortisol, because that is the big stress hormone, and cortisol, as we know, causes edema because of the really high increase in sugar in the blood and the fact that it's pulling things, and therefore you will end up with, right back here again, with the fluid changes, right? Okay. Sudden onset, as in it comes on pretty fast. It can be very severe and even cause nausea and vomiting. Nobody likes to all of a sudden start spinning around in circles with a ringing in your ears and you can't hear. It's rather distracting. Okay. Clinically is how we look at it. You do a little bit of balance tests. You stick the scope in there, look at the ears. If you have to, you do a CT, MRI to try to figure out if there's some kind of mechanical dysfunction going on in there somewhere. Of course, you're checking, for infections, clinically speaking. You're checking for, fluid, hydration, that sort of thing. Okay, so that makes sense why you would treat it with a low salt diet, because salt, of course, sucks water into it, and you don't want to have too much fluid in there because of that. There are medications that you could take. Again, maybe they're diuretics or something like that, which is what's here. Surgery, okay, it works in 95% in cases by removing the vertigo and keeping your hearing, because what you're doing is you're getting rid of, okay, if this is the vestibule with the three little, that's really not the greatest, but three little semicircular canals, and the cochlea is kind of attached, and that's the cochlea over here is the one for hearing, and the vestibule and its semicircular canals up here are for the vertigo, or the spinning part of it, or the balance part of it. If you remove the nerve that's going into the vestibule part, then you will lose all of the problems with the balance, because no longer is any of that balance kind of stuff innervated. So it doesn't throw it off, you just completely get rid of it, and then you only have the other side to deal with. Okay? Well, yeah, that makes sense. Obviously you don't want to move the cochlear nerve, because then you couldn't hear either. Arrhythmias are nothing new to us, right? We've seen arrhythmias before. We probably will see them again. Okay, arrhythmias mean, again, every time you see an A in front of a word without, but I don't know that that's necessarily accurate here. It's just irregular. So you could have, either too fast heartbeat or too slow heartbeat, and it's still an arrhythmia. Okay. Obviously, we typically think about them with too fast heart rate, but you can certainly have it the other way around also. Okay, why? Again, electrolytes get messed up. Maybe your sodium is messed up. Maybe your potassium is messed up. And hormonal imbalances, again, you can, if you have like too much thyroid hormone or maybe too much cortisol, those are definitely affect your heart rate quite a bit, and that could mess up you up pretty good too. Okay. Any kind of thing, anything that puts stress on a heart could cause either too fast or too slow of a heart rate. Okay, so heart disease, hypertension, sure, caffeine, drugs. The postural orthostatic tachycardia arrhythmia, basically what that means is it's kind of, again, like that underdog thing where it depends on what position you're in. Orthostatic means as you're like standing still, then you get tachycardia, which is a really fast arrhythmia. Okay, so your arrhythmia is, not normal. Your tachycardia is fast. Orthostatic is like standing, and your postural is, you know, whatever position. Okay, so you get postural orthostatic tachycardia arrhythmia would be maybe you all of a sudden you stand up. Okay, if you stand up really fast, then it can actually cause your heart to be affected as your normal heart rate either speeds up or slows down. Usually we're talking about speeding up when something like happens like that. I would say a lot of times you're talking about you're dehydrated and that's why it's happening in the first place, but you know, not necessarily. All right, there are other things that can do that. An arrhythmia, so you've heard of people say your heart skipped a beat, you know, because it may have. Okay, fluttering, you tend to get that when your heart's beating really fast and not squeezing all of the blood out on every deep power stroke. Okay, that, of course, anytime you're messing with not getting enough oxygen like you should, it hurts, and it can cause you dizziness, syncope, or it could be totally asymptomatic, so it just kind of depends. Okay. Test it obviously with an EKG to make sure that you are not having a heart attack or something like that. You can go ahead and put it on a 24-hour Holter monitor. What that is, oh, actually, that's what this is you get, basically it's a little EKG unit, and you strap it to your side and you carry it around for a day. And it constantly is monitoring your heart rate through the EKG, and then when you're done with it after 24 hours, you take it back to the cardiologist. Cardiologist looks at it, reads it, and it'll tell you if any time during that 24 hours when you were wearing it, if you had any kind of too fast or too slow heartbeat and for how long, and that gives them a lot of information on where to go to from there. Okay. Chem panel, sure, including hormones. You just want to find out if there's something chemically responsible for your too fast or too slow heartbeat. That only makes sense, right? Pretty heartbeat in there. And that is the end of the show. That's all, folks.